Hello, good evening, everyone. Can anyone confirm if I'm audible?
Sir, you're audible.
Thank you, thank you. So, good evening to everyone. So, today's topic we are going to talk about acute stroke management in the ED, right? So, stroke is a deficit which can leave a person with a lifelong disability if not acted fast. It is a neurological emergency. So, every minute counts, every second is a brain cell. Okay, so there's not a lot of education with regards to this. There was recently a survey was done by the Indian Society of Neurologists to find out that during in the lay persons, about 75% of them were not aware of stroke and stroke symptoms. And what was much more contrasting or shocking in this study was the people who were most not aware about stroke were the rural population and not the or the urban population, but not the rural population. So the well-read and literate were not aware of stroke and stroke symptoms, right? So to not make this monotonous, I just want to start with sharing my own personal experience which we had. So about 2 months ago, my father's elder sister's daughter, she had some problems, so it's a sent a CT brain report to me. So I had a look at that and I can very clearly see a bleed. And I immediately rushed and called them and asked what happened. They said nothing. She had some weakness. We took her to physiotherapy first. Okay. So the physiotherapist very happily did some physiotherapy. And then they said took her to some Ayurveda doctor to buy some oil and do the massage. So finally, when the problem became bigger, maybe she had a midline shift mass effect and she completely collapsed, then only they took her to the hospital and the doctor just rightly diagnosed that there is some neurological deficit and got a brain imaging done to find out that she had a hemorrhagic bleed in her brain. So this can happen to the best of us. This can happen to our own family and relatives. So the government of India very much is driving it to educate the general population about stroke and stroke syndromes and how to reach to these hospitals very fast. And also we as emergency physicians, the emergency fraternity, we are conducting several camps and symposiums, patient education initiatives where we are also trying to educate them about this. So we are going to very briefly now look into what if someone comes to us with a acute stroke and what can be done for them in the emergency department. Right, so is everybody able to see my slides? Can someone confirm that they're able to see my slides?
Yes, sir. Yes, seeing, sir.
Yeah, thank you, Prashant. Yeah, so this is what is the load, right? So you can see the number of people who are affected with stroke, and the majority burden is middle and lower income countries like our India. So as I told you, more than rural India, the stroke load or affected population is in urban India, and unfortunately they are not aware of it. And majority of these strokes are ischemic. So if they present in the window period, we can do something about it rather than a hemorrhagic stroke, right? So this is more. So as we speak, 3 strokes are already happening, right? So not going a lot into a science of this because that's not the intention of this session. We already hope that you know the science behind this, but in a nutshell, a stroke is anything which is causing disruption in the flow of the blood, resulting in hypoxia and eventual necrosis. So there is no blood flowing across. There is where blockade. It can be because of many reasons, right? So there is no blood. The brain cells are dying because there is no perfusion. So stroke is of 2 types. One, ischemic, where there is a block, and 2, there is a rupture, hemorrhagic, when there is bleeding in the brain. So if it's a hemorrhagic stroke, there is not much we can do about it because already the hemorrhage has happened, the secondary damage has happened. The treatment is more about life saving and conservative. But when it is a ischemic stroke or a clot, we can do something about it and we can lyse the clot or break the clot to prevent the patient from, or give the patient a best chance of either not having a lifelong disability or having it in a minimal form, which can be slow. The quality of life can be slowly improved over a period of weeks, months, and years. Any recovery for a stroke patient, if at all it happens, is in weeks, months, and years. Never give any false promises to the stroke patient saying that we are going to give you a magic drug, that is your tenecteplase or altiplase, and you are going to feel get better. Okay, we can only do our best. How well the patient is going to respond to the treatment depends from the patient to patient, right? So we have to be fast. What is this fast, right? So if we are not fast, as you can see, we are, see how many neurons, fibers, everything we are losing. Okay, so what is this fast? Let us look at that. So the guidelines which we are following here is the American Heart Association or American Stroke Association guidelines, which have a, which say that the door to needle time for a patient who comes to the hospital should be within 60 minutes, which has a, which is a class 1 recommendation with a level of evidence of A. So in any publication or guideline, the highest recommendation which can be is a class 1 recommendation. The highest evidence which one can give is a level of evidence A. So this is a strong guideline. There is no doubt behind this. So this is what we have to do. So if a patient presents to our emergency, we have to either take a decision. If we are lysing, we have to lyse within 60 minutes, so before the window period closes, right? So for us to be able to do this, we have to be able to be ready. So these are all the various factors which are going to affect the door to needle time, that is arrival, when the patient is going to arrive. Sometimes it is early, sometimes it is late, sometimes it is too late. So what is this too late? So your 4.5 hours from the onset of symptoms is your window period. Once that crosses, the patient cannot be given a TPA. The patient will have to be given, can only be maybe shifted to a neurocath lab for a mechanical thrombolectomy. So the availability of mechanical thrombolectomies, these cath labs, is very less, and most commonly in well established emergency departments who have support of neurologists, they do the thrombolysis. Okay, so arrival, then emergency assessment. So you have to assess the patient. How we are going to assess the patient, we are going to look very shortly. Then it has to be a team approach, right? So it is stroke team must be there. Every stakeholder in this team has to be alerted. It's not like once the patient has come, after 20 minutes or 30 minutes after you have done the CT scan, then you will take your cool time and then call the person and say, "Hey, 30 minutes ago one patient come, I have done all these things, now you come and see." So every stakeholder, team member in the team must be informed. So we are going to see who are the stakeholders and who are these team members. Okay, then we have to perform our CT scans, do the relevant blood test, and the assessment has to be done. And if the patient is a candidate eligible for thrombolysis, first you have to take the consent, right? Consent taking is very important in emergency medicine or any branch of medicine for that matter. So this consent is best taken from the patient if he is in a condition to make a decision for himself. If the patient is not in a condition to make a decision for himself, the patient is in altered sensorium, then you have to take the consent from the first attender or the nearest attender, that is the father, mother, or the spouse. Okay. So your departments who are going to be involved is your ourselves, first the emergency department, then the neurologist, then the radiologist, and the intensivist. So these are the four relevant stakeholders or the team members we were talking about. So as soon as you have a stroke patient, you have to inform all these stakeholders, because we have a 60-minute target to take the definitive action. So once you inform, as soon as the patient is there, the neurologist will be ready, the neurologist will come to the emergency, the radiologist will not put any other patient for a contrast study or plain study or whatever study in the CT scan machine. Some hospitals have several CT scan machines, some hospitals are not so resource rich, they have only one CT scan machine. So if you don't inform the radiologist, he is going to start some other patient, and once they start doing some other patient, they cannot stop the ongoing study. So we have to be wise and we have to inform them. Then we have to inform the ICU doctor who is going to make the ICU bed ready. So all the stakeholders are going to be ready to provide care to the patient. So this is the optimal stroke team, right? So what are the roles and responsibilities of this stroke team, right? So first you have to be fast. The be fast is a more of a layman's term. It is more taught to the layman, right? So your B stands for balance, whether the patient is having any loss of balance. Then eyes, is the patient having any fixed vision or blurred vision. Then fast, F for face, any deviation of the angle of the mouth. And A stands for arm drift. Any stroke patient, if you keep the arms this way, they are going to fall. Any affected limb, the arm is going to slowly drift. They are not going to be able to hold their arms erect. And S is for speech, that is the slurring of speech. And T is for time, right? So time is brain cell. So the earlier you take action, the better it is, better outcome we can get. Okay, so within 5 minutes of arrival, we have to do all these things. Within 5 to 10 minutes of arrival, we have to inform the neurologist, radiologist, perform the NIHSS scoring, perform a ECG, take a blood glucose, and we have to perform a IV axis and also take the relevant blood samples which are going to help us treat this patient and then shift for the scan. So within 10 to 20 minutes, we should have been done the CT scan. T is for time, Alban sir. T is for time. So the AHA says that T is for time, so that when you identify that the patient is having any stroke symptoms, you alert the hospital and you call for help immediately. So this B fast mnemonic is more for EMS and laymen, for them to be able to identify that a patient is having a possible stroke. We clinicians use a much complex scoring system called as the NIHSS scoring system, which I am going to show shortly, which is part of the health quest document. Okay, so within that 60-minute window period, this is how we are with, these are all the actions which we are going to take, right? Then we have to see whether the patient is eligible for the thrombolysis or not. So you have to look for indications, absolute indications and absolute contraindications. So these are some of the contraindications and indications. So we must be already educated about all these things. Okay, so even if there are relative contraindications, you can do a risk versus benefit analysis and still administer the thrombolytic agent. Okay, and one more thing which we have to remember is blood pressure, right? Never try to address or taper the blood pressure of a stroke victim unless you are planning for a intervention, because the brain is auto-regulating, right? The brain is telling that I am not getting perfusion, I am not getting blood, I am not getting oxygen, I am not getting nutrients. So the regulation is happening so that the brain can be perfused, right? Just because the BP is high, don't try to lower it. If you are planning a intervention, it should be slowly brought to a systolic of 185 and diastolic of 110. And if there is any hypo or hyperglycemia, which should be treated. So all of you might already be aware of stroke and stroke mimics, and hypoglycemia is one of the most common stroke mimics with which the patients present. The patient might not have a stroke at all. The blood glucose might be very low, and if you give IV dextrose, the patient might feel better. So in a nutshell, they are telling, first of all, you 100% confirm that it is the stroke, right? So we are going to see if the candidate is eligible for thrombolysis. You have to counsel, and clearly, once again, you have to explain to the patient, if he's in a condition to understand, or the attender, the risk versus benefit and expected outcome. We should not give a false belief that this is a magic injection. If we put this, the patient is going to get better. Always tell that recovery is in terms of weeks, months, and years with rehabilitation and physiotherapy, right? So now let us see what the health quest document is saying. So this is the health quest document which we are following, right? So this is the stroke care bar thrombolysis protocol. So you have your demographic data and you have your duration, that is your window period. That is, if the event is happened less than 4.5 hours ago. So you have to inform your stroke team immediately. That is your emergency physician, neurologist, radiologist, and intensivist. And we have to do the assessment of the patient in terms of airway, breathing, and circulation, right? Airway, breathing, circulation is the bread and butter of the emergency physician. Even in sleep, we should be able to do it, right? So we have to put all this data, and we are sending this coagulation profiles because we are going to inject the patient with a thrombolytic agent. So within 10 minutes of the patient's arrival, we should have finished this assessment as per the health quest document, and within the next 20 or total 25 minutes, we should have taken a plain CT brain. With that, we will know whether it is a hemorrhagic stroke or a ischemic stroke. If it is a ischemic stroke, then we have to look for the contraindication and relative contraindications, and we have to see whether the patient is eligible or not. Then the most important thing which you have to always do when a stroke patient presents to you is you have to fill the NIHSS scoring system. That is your National Institute of Health Science. Okay, so you have to fill the scoring systems. You can see you have 10 11 different criteria based on which you have to score the system. The training for doctors, especially young doctors, must be provided, and they must be reassessed so that they do the this scoring system accurately, because this scoring system is what is going to help us assess the patient and see if he is eligible or not, right? So if the score is 0, obviously it means that there is no stroke. If it is if the score is 1 to 4, that means it is a minor stroke. Once again, no intervention is required. If the score is 5 to 15, it's a moderate score wherein the intervention can be done. 15 to 20, it is moderate to severe score where the risk is high but benefit is also high. And 21 to 42, it is a very severe stroke. Again, it is very risky, and which patient is not a ideal candidate for your thrombolysis. So ideally, if the stroke patient comes in the middle of night at a 4 a.m. or 3 a.m., your neurologist is not going to say, is he moving his hand? Is he able to speak? Can you see the deviation of mouth? Is there any slurring of speech? As I said, all these things are for the layman. For us doctors, your neurologist is very simply going to ask for your ABCD assessment, whether the patient is stable or not, what does the CT brain show, and what is the NIHSS scoring system. right? So you have to, and the scoring should not be done just once. Repeat scoring can be done, which will give us a better idea. Maybe you can do once before the patient arrives, again you can do after the CT scan is done. So it will give us information whether the neurological deficit is improving or worsening or deteriorating. Sometimes it can improve, sometimes it can deteriorate. Okay, so we will now see a video tutorial about how this NIHSS scoring is done.
To the National Institutes of Health stroke scale. The composite score ranges from about 0 to 42, which is deep coma. The score is used to compare improvement or deterioration over time. It is a communication tool between the emergency physician and the stroke neurologist and guides a decision to administer thrombolytic therapy. Thrombolytic therapy can be contemplated if the score is higher than or at 4 and less than 21. Scores outside this range represent conditions that are either too mild or too severe for thrombolysis. The contraindications to thrombolytic therapy are similar to those for thrombolytic therapy in acute myocardial infarction. However, the NIHSS website or standard textbooks should be referred to when trying to evaluate a patient for thrombolysis and to look at the list of contraindications to thrombolytic therapy. The NIH stroke scale is an ordered exam with each category scored upon completion. Scores should reflect what the patient does, not what the clinician thinks the patient can do. Except where indicated, the patient should not be coached. Choose a response even if a full evaluation is prevented by obstacles such as an endotracheal tube, language barrier, trauma, or bandages. A 3 is scored if the patient makes no movement or demonstrates reflexive posturing in response to noxious stimulation. The age and current month must be correct. Also, score 2 if the patient cannot comprehend the question. Score 1 only if the patient cannot speak for any reason other than aphasia. Ask the patient to open and close the eyes and grip and release a non-paretic hand. Substitute another one-step command if the hands cannot be used. Give credit if an attempt is made but not completed due to weakness. If there's no response to the command, the clinician may pantomime the task. Test only horizontal eye movements. Caloric testing is not done. For conjugate deviation that cannot be overcome or isolated paresis of cranial nerves 3, 4, or 6, score a 1. Total gaze paresis and forced deviation not overcome by Dahl's eye maneuver scores a 2. Test the quadrants of the visual fields by finger counting, finger movement, or visual threat. If one eye is blind, score visual fields in the remaining eye. Score 1 for quadrantanopia or extinction. Score 2 for hemianopia. Score 3 for total blindness. Ask or encourage the patient to show their teeth or raise eyebrows and close eyes. Score symmetry of the grimace. You can use noxious stimuli in the poorly responsive or the non-comprehending patient. Motor arm rates movement in the patient's extended arm. The patient can be either supine or sitting. Test the non-paretic arm first. The patient can be encouraged, but not with noxious stimulation. Drift occurs if the arm starts falling before 10 seconds. Motor leg rates movement in the patient's extended leg. This is done only in the supine position. Test the non-paretic leg first. The patient can be encouraged, but not with noxious stimulation. Drift occurs if the leg starts falling before 5 seconds. Looking for evidence of unilateral cerebellar lesions, limb ataxia is done with eyes open. The finger to nose to finger and heel to shin tests are performed on both sides, and ataxia is scored only if present out of proportion to weakness. The sensory exam tests for hemisensory deficit. Response to pinprick or tactile sensation, rubbing on arms, legs, trunk, and face is scored. Hands are excluded from testing. Only sensory loss attributed to stroke is scored as abnormal. Best language is a comprehension-rich test based on the patient's description of an action-oriented picture, the naming of 7 items in a picture, and the reading of 5 sentences. Comprehension scores are based on the correctness of these responses. If the patient is thought to be normal, a sample of speech is obtained by asking the patient to read or repeat a series of words from a printed list. If the patient has severe aphasia, articulation of spontaneous speech can be rated. Scoring of extinction and inattention is based on prior scores, especially visual and sensory tests. For no abnormality, score is 0. Score 1 for extinction to only one modality, and score 2 for profound hemi-inattention or extinction to more than one modality. Good afternoon, Mr. Jenkins. It's nice to see you. How are you today?
I'm doing fine today.
Great. We'll be asking you some.
So that is a free to share resource. We will be sharing the complete video with you in the link, right? So as a take home message, please remember, educate your team members how the identification of stroke. If you don't have a stroke protocol, if you don't have a stroke team, please form one. Have your own hospital protocol about who are the stakeholders and who are going to make the decision, right? And always educate your patients about what you are going to do. Don't make false promises that you are going to give a wonder drug. Tell them what are the risks and what is the benefit. Explain them what is the risk versus benefit analysis, and make them take an informed decision. And always tell them improvement is going to be in terms of weeks, months, and years with rehabilitation and physiotherapy, right? So strokes can happen to anybody any second. As we saw the data, there are 3 strokes happening per minute in India. So we can have a stroke patient in our EDs as we are having this lecture here now. So we have to be educated, and we have to educate the patients to give them a best chance of having a good quality of life, right? So we have already shared the health quest document with all of you. Please go through the stroke protocol, and if you have any doubts, you can always write back to us. With this, we will conclude this session. If anybody has any doubts, please go ahead.